Good afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program, the Southwest Telehealth Resource Center. Welcome to today's program. So as you joined, of course, some webinar tips and notes, your phone or your computer microphone were muted, but please go ahead and use the chat function. It's down on the bottom of the screen for any questions that you have for our presenters today. There's also a post-webinar evaluation, and CMEs are available for today's session for those that are attending live. The code to text into the Cloud CME portal is in the evaluation. If you don't have that information, it'll be in a thank you email that I will send out to everybody, so you don't need to worry about that right now. You can do that after the program. And again, there's the recording will be available on our website later. I'll have that in the thank you email too. You don't have to worry about writing that down right now. All right, so everybody also saw this as you were registering. These are the continuing medical education, our outcome objectives, the accreditation statement, relevant financial relationship statements, and again, attendance tracking will be in the Cloud CME portal, and you'll be able to get that information in the email I send to us afterwards. We have a standard disclaimer. I'll let you read that. And again, please check our website for upcoming webinars. My two esteemed presenters today will be doing another webinar next week in their other series, the Inventimation series. It's going to be a fun wrap up of the whole year of those sessions. That'll be fun. And we've got a bunch of other presenters coming. It's going to be a panel discussion. And again, your opinion is valuable to us. Please go ahead and do that evaluation. That's how we get more topics to bring to you, our audience. All right, so today's session is called Inside Access Telemedicine for Incarcerated Patients, and we have Dr. Stephen Potts and Dr. Larry York. They facilitate the HIV clinic with the Arizona Department of Corrections, and they're going to be talking about the clinic, what they do, and everything about telemedicine for incarcerated patients. So without any further ado, I'm going to go ahead and pass it over to Dr. Klotz, and here we go.
Okay, thank you, Melanie. And good afternoon, everyone. Thanks for joining. I thought what we could do in the next 45 minutes or so is for Dr. York, Larry, henceforth. We just have a little discussion about what we do every week. And the point is, this is not for planning, it's maybe to help you decide that A, you want to do telemedicine, B, to take it to the Department of Corrections, which is a big system or administration here in the state of Arizona. We do telemedicine every month or week, if you will, to some 17 or 18 different large prisons in Arizona. So our backgrounds are the following. I'm an infectious disease physician who really began this business with HIV, which we're going to mainly talk about, but it's in respect to Department of Corrections, where we started back in 2006, we started a program to do that. But I've been taking care of HIV patients since 1981. Larry York is a pharmacist, years of experience with HIV care and running what we call PrEP, which you'll hear about, and PEP clinics, and is just an expert in the antiretroviral drugs or any other drugs you care to ask him to address. And years ago, I founded this HRSA-funded clinic here at the University of Arizona in 2000. And Larry and I have both worked with this for years. As I said, we started a telemedicine clinic for HIV in the Department of Corrections, mainly for HIV patients, and have since treated thousands of prisoners in the Arizona Department of Corrections. And from now on out, we may just refer to it as DOC. Larry and I have served on educational grants for the state of Arizona, all with some tie-in to HIV, and given lectures throughout the state on HIV. So in 2019/20, all of our HIV patients, of which we had well over 1,000, and probably as many again in the Department of Corrections. We switched them from a brick and mortar clinics to telemedicine in response to the COVID-19 pandemic. Consequently, we have conducted HIV telemedicine clinics, each for a half-day session every week, one special one for incarcerated individuals and others for residents of Arizona with HIV. Our telemedicine clinics for the Arizona Department of Corrections began in 2006, and ever since its inception and beginning, we have been using it or using a concept where we have 3 individuals on every video with the client, prison, or patient. And these 3 people are the infectious disease physician, myself, the pharmacist, which is Larry, and a clinic coordinator who you will meet later. And we initially established this for HIV patients, but over time in the Department of Corrections, we expanded to include all other sorts of infectious diseases that are readily found in prisons. This involves a contract with a healthcare group that oversees Arizona prisons and county jails. They're actually have a contract with the University of Arizona and Banner hospital systems to pay for our services. The prisons or jails, in some circumstances, schedule times for the patients to appear. They send us medical data beforehand, and then Larry and I will make the follow-up as we determine for each patient. The prison sites maintain video health clinics and man them during our visits. So there's always someone on the other side who can manage their cameras and is in the room with the incarcerated patient. Now, our Department of Corrections telemedicine clinics started with, we had very little information. We were generally sent CD4 numbers, which are a measure of immunity, and viral loads, which gives you an idea of how controlled the HIV infection is. And many times, in the old times, we get resistance patterns for the antiretroviral drugs, which were constantly changing because the corporations doing them were different, et cetera, et cetera. Only Larry would remember and could interpret. The medical history from the Department of Corrections often came, but not always. We had the ability to order any lab tests we desired, and we could also dispose of the patient in which we thought was appropriate, meaning going to another specialist or perhaps having them back in a week to consider their labs. So with time, and since 2006, a lot has changed. We soon appreciated that once the patient is stable on heart, CD4 numbers had little predictive value. They very, very little. And unless someone had another infectious disease complicating their HIV, they rarely changed much. We came to understand early that the viral load really had all the predictive power, and that undetectable equals non-transmissible, even in a prison. And this usually translates to less than 200 copies of reverse transcriptase per microliter. If you can stay under that number, the patient is extremely unlikely, almost never will transmit the disease. The key there is keeping them on drugs and keeping that below that magic number. Most of them are, in fact, not even detectable on current tests. Once the patients were placed on integrase inhibitors, which we got to about a decade ago, a little more, it was apparent the disease could be controlled. The virus could be controlled, and hence the disease that followed it and all the OIs or opportunistic infections was controlled as well. Now, little has changed since, other than attempts to approach common sexually transmitted diseases, which Larry will talk about later. Okay, so what we learned also, because we stumbled through a lot of things in the beginning, this was, 25 years ago. Well, one, you need a physician with experience and knowledge of HIV infection and what it's really like, who can use the electronic medical system, has to make the charges for the patient visit. I think it's important to have a pharmacist or a nurse practitioner with working knowledge of caring for people with HIV, familiar with HIV and other drugs, side effects, and ability to write scripts for the same. In our case, Larry became an expert on hepatitis C drugs and has since remained that and sort of does it on his own. A clinic coordinator was also present, excuse me, on every visit for scheduling purposes. And she had to possess a really intimate knowledge of video system and the EMR, electronic medical system, that was being used. And most importantly, she had to have the capability to solve the other end of the system here, the patients or the Department of Corrections, to solve their internet problems, connecting videos, etc., which 5 years ago was a big thing every time we turn on the electricity. Well, to set up an effective HIV telemedicine clinic, I think you need to pick a day of the week. Always want it the same day. It should be a half day long. Select 2 other individuals, which we've already discussed, to be present in the telemedicine clinic, either in person, but at least in video. Choose the telemedicine software for the video. This is often something that the users like Larry and I had little emphasis to affect. And you need to have an EMR that you're going to write the records with these patients with, so that's important. But those 2 elements you probably already have or know of what you can use. Each HIV patient not only can see you for HIV care, but should be told, really, you've got to meet with your primary care physician at least twice a year. Because a lot of other things come up. They have nothing to do with HIV. And our clinic became so busy, we could barely handle what we had asked. So the advantages of telemedicine over brick and mortar clinics are obvious to every practicing healthcare worker. But one you won't know about is that the attendance to a telemedicine clinic is much better than it is for brick and mortar clinic participants. You have the ability that clinic coordinator has to efficiently use 20 minutes of an allotted visit for whatever is needed, and or switch to another patient if they don't show up, or the visit prior is shorter. You can just keep moving on. So rarely do we spend a half a day actually doing telemedicine, because everything, even though we have 12 patients, or did on many occasions, they were all over much more rapidly than what you can do in a brick and mortar.
I think at our height, we had like 20 to 25.
Yeah.
Don't recommend, but we were able to see several people in one day with this setup.
Yeah. Yeah, no, Larry's absolutely correct. So it's convenient for the patients because they don't have to travel, nor do the prisoners. It's convenient for the clinic personnel because they don't have to travel either. And in that, people are saving money. Department of Corrections, the employee, and there's there's no structure needed for this to occur. It's all video. So there's a lot of savings. It's inestimable. Experienced physicians fare best on telemedicine not because they're better, they've been through the hoop hundreds, thousands of times and can recognize where the story's going and what the problem may be, if there is a problem. Fortunately for HIV patients, there are few problems anymore, not relating to HIV. Take the drug, disease over. Since there is no physical contact between the patient and interviewers, the interviewers must learn to ask for surrogate information. For example, if you're following someone for heart failure, you could ask for, what is your weight today, and compare it to what it was when they were dry in the hospital or whatever. And furthermore, you can scan down with these new videos and actually have someone, the patient, maybe press on their front of their leg and actually visualize the leg edema. Some of the disadvantages are, well, in my mind, and I think in Larry's too, there are very few disadvantages. However, what has happened is that the value of a telemedicine visit has suddenly been determined to be less than an in-person visit. So the payment schemes are not as good. This is not really well thought out. And furthermore, many of the senior leaders in medical organizations, they haven't used telemedicine. They don't appreciate its scope, its utility, everything you can do. I mean, it's just amazing. That's why Larry and I continue to do this years later, is we're just committed to it.
And I think the thing that's overlooked, I mean, the technology that we're using now is stuff you go to, Walmart and pick up. I'm just using a regular webcam, a regular computer. You don't really need any fancy technology to accomplish this. And yet you're able to see more folks. I think the reality does sit in for a lot of these conditions we're seeing. How little utility there is to really having that in-person evaluation, that the information you need can either be obtained from the patient. As Dr. Kloss mentioned, there's usually an on-site nurse or some sort of individual that is able to visualize or do more of an assessment if you really felt that you needed it. So overall, I mean, just emphasizing a massive time saving, seeing more individuals, optimizing healthcare, and with really, I would say, no significant additional cost on the part of us, truthfully.
Right. Yeah, it's just incredible all the savings you can envision going on as you are doing these, and how you can improve on everything. So Larry and I, over the years, have improved the clinical experience every time we use it. Say, no, this is not working. Let's do this. And as I said in that little slide about the evolution of our thought about these and our experience, I mean, things began to change over time. First, all we had was just trouble with our clinic manager trying to get the Zoom thing up or whatever it was. We were on so many different programs because of the people we worked for. Some of them were good, some of them were terrible. And even today, it still goes on because I'm sort of frustrated with Zoom, but I sort of like this Google Meet or whatever that is. That's so simple. They keep uploading stuff. Anyway, so here is our clinic coordinator, Crystal. She's still with us. This is a picture of her in her environment down here below the library at the University of Arizona Health Sciences Center, in which we have a whole studio. I mean, it's packed to the gills with all this state-of-the-art electronics that we don't use anymore because, well, we went through COVID and they closed everything down. and who's coming back. Anyway, she's our clinic coordinator. She oversees the continuity of the clinic. If she weren't there, we wouldn't know what the heck's going on. So she's contacting the Department of Corrections every week for patients that we're going to see every week, gets their names and documents their appointment in our EMR, which is important for the organization. And she has to have some knowledge, if not a very, I would say a working knowledge of how to all the video aspects and the EMR. And most critically, she has to have the ability to help the other end of this contact, the patients that we're seeing on her, how they can upload material and integrate with this whole thing. And fortunately, even the most advanced elderly like myself, they learn in 1 or 2 tries how to do this. Wouldn't you say, Larry?
It would. I mean, I think it does highlight really doing, I think, the best telemedicine that you can is a team approach. And it's not just having a pharmacist or this or that. You really do need an individual that can just handle the logistics, all of the administrative issues that come with it. I mean, when we're doing our clinic, we may just be sitting there having a great time, and poor Crystal here is interfacing with these different facilities. There may be some last minute changes. Patients may get moved here or there. Maybe a yard has gotten put on lockdown and people aren't going to be able to be seen. Or every now and then we'll get someone that shows up that isn't on the schedule, or they're a little bit early. And she's grabbing records from these individuals, getting them to us. And I mean, she does a fantastic job, but we've reached a point where it's almost seamless. You don't realize that this is happening behind the scenes. So there's a lot of chaos, I think, in the in-between. But really, just this one individual it seems like every week goes very smoothly for the both of us seeing these individuals.
Well, I plead guilty to not taking my Flonase this morning. Good. Yeah, sorry, folks. Anyway,
We're all dying of allergies, don't worry.
and here is Larry in his old suite with, look at all those cameras. Good night. So he talks to every patient that we have, covers all their medications, including over-the-counter medications, which is a big deal. Patients with HIV, because they're on vitamins and things, lots of drugs that could interfere with their most important drug, which is the antiretroviral therapy. And he, make sure they're taking it with food or not. It's what's really required here. And I can tell you, I've been doing medicine for so many decades that remembering all these things that a pharmacist knows is impossible. So you shouldn't even ask a doctor, honestly, or a physician. And I mean, of course you should. I'm not
Bingo. To make a point.
Yeah.
And I think, I mean, the other thing I do just with the clinical background is Dr. Kloss may be speaking of the patient. And with some of these individuals, you may not get all of the records that you initially want, or maybe there's missing pieces. And with access that we do have to Sonora Quest or to LabCorp, I'm able to go in, see if there maybe is something relevant to us that was missed, or some historical piece of information that may shed light on something. So just having an extra individual that is some manner, I think, of clinical, I mean, yeah, absolutely having a pharmacist, I think, is great. I'm not going to throw my own profession under the bus. But I think just having that second person that can help man some of that back end for the clinical aspect can save the physician a lot of time, the provider a lot of time in what they're trying to do.
Well, I'll just wrap up my portion here, Larry, with one last comment, and that is, for those of you who are listening, I hope we can recruit some of you to say, yeah, I think I'll give Department of Corrections a chance here. I mean, it is so much fun. And why is it fun? Well, this is an interesting group of patients that you've probably never seen before. I used to go to jails and prisons all my career, here and in different countries. But these people need us too. And so it's a service, and I think Larry feels the same. But it's actually doable, and you can make some very critical changes in people's lives and improve their lives through good medical care. And this is particularly true of patients with HIV, as I'm sure you all understand, which is lethal if you don't do anything about it, but it can be easily addressed and managed entirely for the patient's life. So I'll turn it over to you, Larry.
I think the biggest takeaway, I was talking with Dr. Klotz about this a while ago. What I enjoy the most about telemedicine is that it often is a bit unrefined. There's a bit of an element of chaos to it that I think therein allows folks to be able to innovate in a way that maybe they haven't in a while. It's really, we're sort of pioneering something new, figuring out the best ways to do this. Some ways work better than others. But I think going back to what Dr. Klotz mentioned about the ideal individual for doing telemedicine, I think particularly working with Department of Corrections, is accepting that there's a lot of steps for information to get from one person to another. We may be having information coming from a provider that seldom sees a patient there. So a mid-level practitioner may be trying to do their best to interface with us, get us what they think we might need. And I think accepting that it's not going to go as often some of the brick and mortar clinics do, where I think we all expect every lab value is there, it's immaculate, we have all the information that we want. There is a lot of missing pieces, especially with Department of Corrections telemedicine. And I'll be honest, I enjoy that aspect of it. I mean, oftentimes the individual may be seeing us and they don't know why, and we may uncover something that maybe even wasn't a major concern at the facility or was something that was overlooked. So I think approaching Department of Corrections with this open mind, you may not have all of the pieces of information that you're used to, but certainly you can recommend things. Someone can help to get those values obtained if they're critical. But really, I have enjoyed the puzzle solving aspect of it more than anything. And while I think it favors more experienced individuals, I think telemedicine is really a great place to have trainees and learners come along with, because it presents those clinical opportunities of you're missing maybe X, Y, and Z, but we've got A, B, and C. What's on your differential? What kind of things may be at play here that we need to consider? And I think it makes for great discussions, honestly. In dialing it back to Crystal, I think now we have a third individual that manages all of this. We've got the luxury to sit there and have these conversations with the trainees, with the learners, while this poor girl is back here trying to put out all the fires and connect everything up for us. I mean, I think there is so much hidden value to doing, certainly Department of Corrections telemedicine, that I think if people approached it more with an open mind, you may not be making the substantial impact that you think you should be able to with your training, with your background. But what you're bringing to the table is already so far beyond what many of these patients are used to. You can only improve the quality of their care. And this is a very different setting that we're dealing with. It's not going to be like what we're seeing on the outside. Definitely, it takes a bit of time to, I think, get into the flow of things. But even the smallest thing you're able to do for these individuals, massive impact, honestly. And you're really helping out not just the patient, but these individuals at the facility who I get the sense are doing their best just to keep all of the fires out. And it seems like half the time it's madness in the background. You can hear people coming and going. There's lockdowns. There's all kinds of things happening at these places. It's never a dull day. I'll tell you that when it comes to telemedicine. But this last portion here is dialing it into telemedicine as it relates to HIV care, but highlighting some of the areas where HIV care is changing in, I think, a way that favors more the use of telemedicine. But talking about not only the way telemedicine can improve PrEP and PEP care, we'll talk about what those two things are, and frankly, even as brick and mortar concepts, vastly underutilized things that I'm not sure who all that we've got here, but if you're practicing internal medicine, family medicine, absolutely something that I think is of major value in just everyday clinic. So just highlighting a couple of changes, as Dr. Klotz alluded to, I would say direct HIV care, getting the viral load down, which is our key aspect. It's almost boring at this point. We've reached a point now, we have a plethora of very safe medications. Hopefully we're still on. All of the lights just went off. All right, I think we're still with you.
Hold on.
No worries. Massive power outage on our end. All right.
Hold on.
We've got to have some challenge. We can't walk through it. This is a great emphasis on telemedicine right now. You never know what's going to happen. Early on, we were having issues with some individuals connecting. So using Zoom, we're able to backdoor individuals in. I have Dr. Klotz call my cell phone, and it brings them into the Zoom. So again, I think just keeping your cool when terrifying situations, but always a way around it when it comes to technology. All right.
Hold on.
Oh, no worries. Oh, we might crash with this one. I think we're still in here. I'm still seeing the time.
Zoom's not responding. I mean,
All right.
Ref, can you hear us?
Yeah, what's up?
Can you still see us? The cameras went off in the room here.
Your camera is on.
All right, and you can still see the slides?
No, these slides are not showing.
Okay, hold on a second. Let's stop share. We'll see if we can. Yeah, I got, Zoom was not responding. Hold on a second, please.
That's all right. In worst case, if we can't get the slides back, they're always posted afterwards. And we can just go along on our way. Let me pull up some here. We'll go by mobile if we have to.
Well, they could put some questions in the chat too, if they have it.
Yeah, if anything comes up in the, well, if we can see the chat might be gone.
Yeah, Ref, I can't stop share right now. I think I might have to disconnect and reconnect. That could be bad. All right.
Well, do you want to let Larry just continue? You could talk about PEP and PrEP.
Yeah, the slides really are meant to just be bullet points for the content.
Okay.
We're good to keep going. I have got slides, and I will hope my phone doesn't die, then we're in real big trouble. But I think we're good. All right. So some of the major changes, truthfully, you're seeing a big change in the HIV landscape. Honestly, away from direct HIV management, because as glib as this may sound, that problem's pretty well been solved. We have plenty of new regimens that have come out. We've got long-acting injectables. We've got probably in the next maybe 3 to 5 years, weekly pills, monthly pills that are going to be coming out. So you're seeing a lot more emphasis now on the primary care aspect of HIV. And this is where, going back to Dr. Klotz's point, I think if you are joining us and you're a regular family medicine or internal medicine practitioner, I think now has never been a better time to get a bit more skilled in HIV care. Because truth be told, you're going to probably have a much bigger impact on these individuals' welfare than we will at this point. We just get them started on the meds, and they still need someone to watch them a bit more closely for cholesterol. There's been a study that's come out called the Reprieve study. basically, if folks with HIV are above a particular ASCVD risk, and there's controversies with this to be sure, but there is renewed interest in possibly starting a lot of these individuals on statin therapy, or at least having that discussion with them about the risk of cardiac issues down the road, which no matter what we do to manage HIV, these folks tend to be at higher risk for heart issues later in life.
All right, we're getting connected here. Can you hear me?
Yes.
Thank you. Hold on one second here. Let me get the file to close. Go. No, we're gonna get right back to our slide. Thanks for hanging with us, folks. We've got right here.
All right,
Well, why don't you just tell them to have it.
that's where I'm gonna put that.
While I'm bringing this up, yeah, we want to
Yeah,
continue.
no worries.
Let's have them prep for infectious diseases.
So I'm not sure where we lost y'all, but the last thing I'll mention, it may be a repeat for some of you. We are now using a long-acting injectable for AIDS. Knowledge about this, there's commercials out there. They may have friends that are on some of these things. And again, I think the way that therapy is going, a lot of our new patients for HIV, not all, but I'd say a large number are younger. And I think the way that things are skewing is entering an era of convenience, maybe for good or for ill. We could have a whole discussion about that. But these individuals want convenience. And basically, we do live in a time where there's plenty of choices. If you are not the most convenient option, they're going to move, in many cases, all of their care somewhere else to an individual that does offer those more convenient options. And HIV care, I think, is absolutely critical for being able to provide some of these meet individuals where they're coming from levels. These are folks that may have a lot of other social issues going on in their lives, or just like a lot of us, just have busy, hectic schedules. It seems like everything's crazy nowadays. Being able to offer these quick check-ins, truth be told, there's very little utility now to seeing a lot of these individuals in the clinic, other than just I don't think you're gonna go get the vaccines I want you to get, so why don't you come on in so I can strong arm you a little bit to getting some of these things for preventive care. But as far as physical examinations go, I would say the majority of individuals, there's really not a whole lot there. Certainly there, I think, should be some emphasis on managing all the basics, blood pressure. During COVID, we learned a lot of hard lessons. We essentially, all of us had to work from home I was home for 14 months, and Dr. Klotz really never came back at that point. He called it quits when COVID hit. And you know what? It was pretty rough the first couple of months. That was a horrible time. But what you discover is there are so many options where folks can go just get their blood pressure checked. We were able to use clinic funds to get BP cuffs to mail out to patients. They could check at home, report back. A lot of different changes that can be made to meet these individuals in the middle. And by doing that, secure their interest in their own care, but maintaining their care with you. I can't tell you how many folks that if we didn't provide some of these options just decided, you know, I may have diabetes, I may have high blood pressure, I may have this, I may have that, but I want an injectable product. I don't want to have to take this drug every day. And here's another place that offers all of these things. I think I'm just going to move all of my care over there. So I think it's critical to look more into this to securing. Can you click the middle one for me? I think it just got off kilter.
There you go.
Thank you, ma'am. So we're just going to briefly talk about it with the time that we have left. PrEP, if you are someone here that practices general medicine, absolutely an overlooked thing that is out there right now, but boiling it down to what PrEP is, this is essentially a contraceptive against HIV, whereas someone may take a contraceptive to prevent pregnancy. This is an antiretroviral an individual can take that can help prevent HIV even if they are directly exposed to it, typically through sexual exposures, but data does support using this for folks that may be sharing needles and do have unsafe injection practices. PrEP is a growing field. If you go back even 6-7 years ago, we had barely one drug that individuals could use. Now we've got 4 different drugs, 5 or 6 different modalities of doing these drugs. And honestly, I think right now is both a great and a terrible time to get into PrEP because there is a lot of question. It's sort of like the box is opened up and we're really reevaluating how do we do some of these things. Lab monitoring is very straightforward. But what it really boils down to is not just simply giving an individual a pill or an injection to prevent HIV. It's a sexual health, sexual wellness visit. And there is so much overlap with what is already being done in these general or primary care visits that I think it's a big miss for a lot of individuals not to look into this. And if I had to pick one thing that is ideally suited for telemedicine, it would be PrEP or pre-exposure prophylaxis care. These are often individuals who they're seeking you out. They've heard about this. They may know that they have multiple partners, or they may just want to have an extra level of protection to protect themselves. They're seeking you out. They may have busy lives. They want something that's convenient. And I will tell you, you don't see these commercials. There are a ton of different online groups providing these telemedicine services. And I think this is one of those opportunities where if folks aren't quick on the draw, you're going to have a whole new, industry of individuals practicing these telemedicine services. And all of the folks that are used to brick and mortar are essentially going to be relics. I mean, I hate to say it. I like a lot about the brick and mortar environment, just getting to be around other folks. But I think no matter how we shape this is the future. I think eventually Medicare, a lot of these other insurances will catch up. And the time is now to get comfortable with how to conduct these visits. So PrEP and telemedicine, there really is not a major indication for individuals to ever need to come and see you in the clinic. A lot of the testing we do can be done by the individual. So one thing that's overlooked, these are, at least in our population, typically individuals that are highly sexually active, and that can be defined a number of ways. They may have multiple sexual partners. They may not have that many, but they may not be practicing safe sex. Maybe condom usage is non-existent for a lot of these individuals. Whatever it be, these are individuals that are at higher risk for HIV acquisition. We typically will do blood tests at the earliest 2 months, usually every 3 months for folks, although even that may change with some of these new drugs. And we're doing HIV screening tests, which during COVID, there was a lot of investment in looking into, can we just provide, you may have heard of OraQuick. These are swabs that can be done. You could go to a CVS or a Walgreens right now and buy one of these things. The long story short, there's a number of home tests that individuals can get access to test for not only HIV, but syphilis. Now, gonorrhea, chlamydia, if folks are having oral intercourse or anal receptive intercourse, gonorrhea, chlamydia, as I think most of the folks here know, tend to stay in those sites where they're initially contracted. So swabbing the oral pharynx, swabbing the rectum, really is a key piece of evaluating these folks and making sure we're checking everything for sexual wellness. Well, very quickly during COVID, we figured out we just gotta set up a kit, mail it to these folks, and they can take it from there. Now, the throat swab, I don't envy anybody trying to collect their own throat swab. It's not fun, but it absolutely can be done. We were inserting a piece of paper into these that showed how to do it. But for all these patients, I was either texting them or emailing them. Here's a really good YouTube video that shows exactly where to hit. You can see a live person doing it to themselves and using that as a guide. Now, the rectal swab, anybody can do this one. It's very simple, just inserting the swab, maybe a centimeter, giving it a swivel and going from there. So all of this, I think that's the reality of it. Let's be honest. It's very easy to do. Now, doxypep is another one which depends on the day you ask me about this thing, but doxypep, whether I like it or not, is here to stay. If you haven't heard of this, if these options, Truvada or Descovy, are tools for HIV prevention, well, doxycycline, in addition to doing everything else on planet Earth in the world of infectious diseases, also has been studied and now has a CDC recommendation for essentially being a plan B for gonorrhea, chlamydia, and syphilis. So if individuals have a riskier encounter and maybe think later like, oh, maybe that wasn't the best idea, or maybe there's some concern that developed as a part of this exposure, they can take 2 capsules or tablets of doxycycline, 200 milligrams total, and just like Plan B, within 72 hours of a high-risk encounter. Of course, the sooner the better. Now, this is, brand new. This is only about a couple of years old. So numbers about how well this works, I can't give you a hard number for how good is it against gonorrhea prevention. But the data that is available does suggest it does work, at least definitely for chlamydia, most likely for syphilis. And depending on the study, gonorrhea is a bit hit and miss about how effective it is there. And of course, gonorrhea has had issues with tetracycline resistance for some years now. And much like injectable options, the sheer number of patients that are coming to clinic asking about this is staggering. Now, I'll admit I tend to think of myself as still being a younger guy that's hip to a lot of the tech stuff out there. But the reality is I'm not. There's even newer things out there that, I'm going to turn a stink face to when people, I'm never downloading TikTok, but even I am aware that this is a big deal out there. But a lot of these apps, so I think a lot of folks may have heard of Grindr. This is one of the most both infamous and infectious disease, but the most well-known. Individuals that sign up for Grindr, a lot of these other sites, they're getting advertisements about, hey, are you aware of doxypep? Are you aware of PrEP? So again, whether you choose to engage in this format or not, it is being actively advertised to individuals out there. And they're seeking these services out. And in many cases, once they're aware, oh, this does exist, they may move all of their care to these more convenient services. Now, PrEP, just to save us some time here, I really think this is ideally suited to a telemedicine experience. So both if you're joining us and you're practicing family medicine, or you think this may be a good fit for your clinic, I would absolutely encourage you to look more into PrEP. As Dr. Klotz mentioned, we do a lot with AIDS education training centers. They do offer training programs. If you want to get a jump start on learning how to do some of this, it's very easy. There's a lot of room for innovation. But at the end of the day, if you're someone that's more regimented, this will absolutely suit you too. And I think will help retain a larger than you may expect clientele of patients. Now, PEP, with what limited time we've got, I'm going to go through this a bit more quickly. This, to me, in the world of infectious disease, is the single most underutilized thing. So for everyone joining us here and folks you may know, we may all have had a needle stick at some point or a fear of one happening, or it's come up in the environment that we work in. But any exposure to HIV, if I'm not taking PrEP, again, that Plan B metaphor comes into play. There is a Plan B-esque option against HIV if, as a practitioner, I've had a needle stick, maybe I'm a surgeon that's had blood splatter into an open wound or mucous membrane. But oftentimes, these are cases we're seeing in our clinic that I hate saying it, it's the reality of it, sexual assault. So we do see a lot of survivors of sexual assault. This we have tried to get to be a key piece of the treatment that is offered after that has taken place and the individual presents to either a practitioner, the health department, or a hospital. Now, PEP, again, very regimented. I would say right here, taking a snapshot in time, even more regimented than PrEP care is where PEP care is right now. There is a guideline update with a fantastic table that tells you everything you have to do, a great roadmap. And there's really only one of a couple of different treatment options, Biktarvy being one of them. This is by far our most commonly prescribed agent for folks with HIV, but we often are using a 2-pill combination that is Truvada plus another pill called Tivicay. Yeah.
Could we jump to
the question here?
The question there
Yeah.
from Maria, I guess it is.
So we have a question or comment here. Let me read it out loud. So public libraries do have telehealth kits and computers, private rooms for a telehealth meeting with a doctor, which is great to know. We often do run into situations where folks want to engage in telehealth and maybe don't have an ideal place that they can go do this quietly or securely. So if the corrections departments have a library, they may be able to work with them to have kits that have blood pressure cuffs, pulse oximeters, thermometers. I will say, as far as Department of Corrections go, that is one of the awesome things, is whether you want it or not, and oftentimes we have nurses that are real go-getters, they'll bring the patient on for their visit. They'll already have all that information for you, just as any medical assistant or nurse in a brick-and-mortar clinic. So oftentimes for what we're doing, the wait is not the most important thing in the entire world. But absolutely, that is something. And if honestly, if we can just pitch you out there for resources, that would be great for a lot of any of these other individuals that may need some of those services.
Well, Larry, don't we, this involves something we've got ongoing from here. The support of
We've been working,
libraries and so forth.
yes, we've been working with,
Yes.
so Mala is with the state library system, we've been working with libraries about the TAPS.
Oh, I see. It's not Maria,
It's Mala, yeah. Hi Mala. So yeah, that is a kind of an ongoing project that we've been working on and helping to get those libraries listed into the TAPS map as well for telehealth access points across the state.
that would be really something.
Yes.
She says like that.
I.
I mean, and that just highlights, like, we're even in the sphere of doing this and don't know about a lot of this stuff. And I think that's just such a shame. This is, I mean, I really do think this is the future. And I think it does just represent, I don't want to say an unwillingness. I think COVID changed a lot of things. And I think all of our brains are baked at this point. I don't we changed a whole heck of a lot in a very short amount of time. I think most folks would just kill for a little bit of stability. But I think we are at that point where whether we want it to or not, the future is coming, technology is changing. This is the future. I mean,
It certainly is.
it may take time, I think, for more bureaucracy, insurance to really reflect that, but it's already happening and that's clear. And I think just by joining us, I hope we've at least sold you on at least some interest, if not in telemedicine as a concept, Department of Corrections trying it out and seeing how that looks. We can always, I think, have folks come spend a day with us now. I think the beauty of our clinic is we pretty much just bounce on and off almost whenever, Tuesdays, Thursdays. Last thing I'll say for PEP, again, the one aspect of PEP is, again, sexual assault survivors. This could be the most stressful time in their life. Really meeting these individuals at where they're at, I think, is key. The retention rates, frankly, are terrible for a lot of these exposures. Folks disappear or they never engage with us. And a lot of folks that later did stated, I just honestly wanted this all to be over. I didn't want to go. I didn't want to do any of this. I just wanted to move past. And I think providing these telemedicine services really does open up access for a lot of individuals to get these services that really, I think, are both undervalued and underutilized.
You're right, Brian. Yeah, and
You
on
go.
this, I think, what would be, we had a lot of interest in other infectious diseases that we were seeing. And it was just amazing the number of bone and heart disease.
That was a big
or infectious disease we saw.
Wound infections, osteos.
And virtually you can count on it. The Department of Corrections is doing a fantastic job with respect to HIV. I mean, it's been years since we've encountered anyone who's uncontrolled without any drugs at all.
Well, in Hep C, I think
Yeah,
we're
Hep C
surprised at
is
the
on-
number of people getting
It's
treated.
been addressed.
Yeah,
And I think the big thing is just remember people that you encounter with HIV, test them for HCV and HBV. And then we have a last slide there that's just some of our recent publications, meaning Larry and I, with regard to HIV and Department of Corrections.
most of these are very short reads. There's some nice tables on them that really just emphasize, at least in the world of infectious disease, some of the major things we encountered, but it does comment on a lot of the learning points that we picked up along the way too. Basically what you got today, but I think worth a look. And then the last thing I do want to mention here is just another comment from Mala, is just regarding the sphere and equipping places to do these services, that we do need more funding to equip our libraries with kits, bookmobiles to take these kits to housing apartments, partnering with nursing schools. I think there is, again, so much room for innovation. And I think it takes a lot of legwork. I think there is a lot of hesitancy. I don't want to be totally down in the dumps. I don't think people hate telemedicine. I think people are burned out. And I do think that folks just want something stable and simple. And I think with just a little bit more legwork, a little bit more input, we can very quickly get telemedicine to being a stable, very viable service that I think most specialties, if not really all specialties, can have a great time with and really reach, I think, both a unique population, but a changing population as well.
Partnering with Molly, you're partnering with the nursing schools, librarians, stuff, they don't necessarily have the skills or the time to assist the patients. That's a very good point. And part of that, getting tired with where current things are, it's being innovative and getting those collaborations put together and thinking outside the box.
And I think finding the center of the calm, because even today you can do everything right, and just like anything in life, man, things can still go wrong. So I think just everything will work out. I've accepted this at this point, but everything will work out. It's worth a try. I would encourage you all to at least give it a shot and look into it.
All right, thank you again for joining us today. Thank you, Dr. Klotz and Dr. York, for sharing your experience. And again, please, there's an evaluation that will pop up at the end of the screen. I'll go ahead and stop sharing so it brings us back up.
And we
And-
apologize for the interruption.
You know what? Internet goes unstable and we've got a punt. So thank you for sticking with us so that we can continue this webinar. It is being recorded and the slides will be on our website later. Again, I'll send out a thank you email to everybody, so you don't need to worry about writing those URLs down. So thank you again for joining us and we look forward to seeing you again. Thanks, everyone.
Bye, everyone. Thank you, Melanie.